Andrés Noé is a medical doctor, a Rhodes Scholar, and one of the clinicians involved with the development and trialling of the AstraZeneca vaccine. So as well as vast experience he has working on malaria and malaria vaccines, Noé has also spent a decade focused on the health and well-being of children and adolescents. He has now developed high-level COVID-19 expertise via these various projects and has led contract tracing teams in the UK. He's currently working at the Royal Melbourne Hospital, and we thought it would be good to get him on for this first episode in the series of Michael St. Alexander Explains that looks at the COVID-19 recovery. So joining us is Andreas, and there's so many things we'd love to talk to you about, and we've only got a half an hour. But first of all, the fact that you've worked in the UK in this space and in Australia now in this space, what can you see of the different approaches between the UK and Australia to the pandemic and the vaccine rollout?
Hi, Shannon. Thanks for having me. It's pretty hard to say, pinpoint the exact differences, but broad brush strokes in terms of the United Kingdom. I mean, obviously, at the start of the pandemic, they kind of hesitated for about 2 to 4 weeks to initiating a national lockdown, and that was around, I think, the late March, because by then the infection was widespread throughout Europe, and there's probably tens of thousands, if not hundreds of thousands, of cases already in Europe, with a sort of gross underreporting. There was only sort of brief border restrictions with China, and much of the transmission throughout the first half and throughout this of 2020 occurred in households and from healthcare workers to households. So that was the kind of context, and it kind of went away. There's low infection rates throughout summer, the European summer, that is, of 2020. And there was an attempt to regional lockdowns, which didn't really work through the second and third and fourth quarter of 2020. But then that necessitated really a national lockdown, essentially from November to I think it was probably June, with sort of a phased exit leading to the Freedom Day, as it's called, in the UK on July 19 of this year, but really that occurred in the context of a tremendous upscaling of vaccine production capacity, as well as vaccine messaging and vaccine procurement deals. So there was like a huge vaccine blitz where 60% of the UK population was vaccinated over 3 months, essentially, this year, and you know, now that's started to tail off a bit, and the harder to reach populations are only starting to get vaccinated now, really, and currently, you know, over 81% of the population is vaccinated over 16 years old, and their hospitalisation and infection rates are in the low thousands and low hundreds respectively. And those are the important metrics to look at when you've got a highly vaccinated population, is the death and hospitalisation rate. It no longer really becomes about case numbers. It's about hospitalisation rates. So that's the UK context. Slow to start, really got going in towards the end of 2020, and then now is really reaching, I think, the limits of what can be done in terms of what we've seen so far. They'll have to have a bit more of a think of how they can extend vaccination coverage. Contrasting that to Australia, I mean, I'm sure you guys are aware there was a national lockdown for a number of months. Australia instituted very tight border restrictions. The Melbourne lockdown of 2020 was a huge monumental effort by the public, because essentially they're the ones that really did the work there, and they sort of conquered a COVID wave that I don't think anyone else in the world was successful in doing. And then 2021, I think that's where things really started to become a bit more complicated for not only the federal but state governments, where there was a bit more of a fragmented response. The vaccination rollout in terms of procurement, messaging, and education started to be a bit more difficult. And obviously there was things that could have been anticipated and unanticipated. For example, the AstraZeneca and clotting, that was something that was very difficult to communicate, and I think probably left a bit to be desired. And that lack of urgency to really vaccinate, Scott Morrison said, you know, it's not a race, but really it was, and it is. but it's not a race against other people. It's a race against the virus itself, which I'm sure you both have heard. And that compounded the difficulties in messaging and led to a state where now, something like 45% of the population over 16 are vaccinated, fully vaccinated. And I think today or tomorrow we'll tick over the 70% one dose vaccinated, and around about 1,500 cases nationally occurring every day. And in this context, like I mentioned before, it is important to look at cases because there's such a low vaccination rate. Cases are directly linked to hospitalisation and deaths. Whereas when we reach a higher proportion of vaccination, then we'll start to see a bit of an uncoupling between cases and hospitalisations and deaths. So really, there's quite a difference in the way that it was approached. 2020 was really the hard work, I think, for the UK, both in terms of people dying, people going to hospital, but then also a lot of procurement deals, a lot of urgency being placed on the government. And 2021, I think, in a microcosm, similarly is what's happening in Australia. Another similarity is that that there's been an inequity in terms of the impact. So if we really look at this from a broad scale, in the UK, culturally and linguistically diverse populations were affected disproportionately by COVID, and the same is happening here now. And then previous to these past 2 months, the economic impacts were borne by culturally and linguistically diverse communities and young parents, Aboriginal and Torres Strait Islanders, people with unstable incomes already. So I think those are some of the broad brush similarities, but then also some of the broad brush differences.
And we'll talk a little bit more about the specifics of the AstraZeneca vaccine, which you have worked on the clinical trials of. So I'm interested there in the switch that we're trying to flick at the moment, which is really an upscaling our vaccine potential, which back in March, obviously Scott Morrison now famously said it wasn't a race. And that was because Australia at the time was able to manage a very low caseload and didn't have a strain like Delta. So I guess what I'm asking you is what your assessment has been on the messaging we've seen from the top end of town and from government as we've kind of changed our path away from, being in the grip of a pandemic.
Yeah. So, I mean, look, I'll just kind of correct you there. I was a very tiny part of the Oxford team. Despite what my mother might have you know, I didn't invent the AstraZeneca vaccine myself. I was only a very tiny part of the team. So in terms of the messaging of the government, it was a really tough game to play. The government was facing, or is facing a pandemic where there's uncertainty of information. It's ever changing, and it's a volatile situation, really. I think there's a number of things that, like I mentioned before, left something to be desired. One of which is having an effective and sort of a solitary unified message, whether that's we need to rush or we need to continue and upscale our vaccination as soon as possible, or whether that's the AstraZeneca vaccine is not safe or it is safe, and we should vaccinate this particular part of our population. There was never really consistency in messaging, and that was borne out across time in the federal government, where they said we're following the science, we're going to listen to ATAGI what they say, or whether that's across the regions, whether Queensland is against the federal government or whether Queensland disagrees with Victoria's vaccine policy. I think those kind of unification of the message is really necessary in communication, whether that's in pandemics or public health or any other field. So I think the communication could have been done a bit better, and I think this is probably something that politicians are great at, but blaming others. At the end of the day, ATAGI, which is the peak body that advises the government on on immunisation, their job is never to dictate policy. Their job was to provide an impartial and credible source of information for the government on which to base decisions. To then say that ATAGI's made it difficult for the government to move forward with the vaccination rollout is just sort of untrue. They're providing the information as it stands. So I think those are two of the difficult areas of contention I would see. But I mean, this isn't, like I said, this isn't new to vaccines and public health. Science messaging, science communication is something for which has been systemically underfunded and disregarded throughout, the past 20 years, really. And it's something that for which Australia would stand to benefit. I mean, if you look at all of the medical funding for COVID-19, all of the medical research funding, $0 up until June this year, or July, I think it was, went to science communication, behavioural modification, qualitative research to understand how vaccines can be implemented on a wide scale. And that's just an alarming statistic, because we spent hundreds of millions of dollars on these therapeutics, on these vaccines. That's great work, and I'm not saying it's any less valuable. But if we can't make someone feel comfortable enough to get a vaccine, then that it's not really, it's missing the point, and it's missing the arm, really. If the jab's missing the arm, it's missing the point, to put it into a short, pithy statement.
You mentioned earlier about the way things rolled out in the UK to Australia, and perhaps the impact in the UK early. It was a much greater impact than what we saw in Australia, actually motivated people to take up vaccination quicker than we did in Australia. But probably the main thing, that the miscommunication perhaps, or the contradiction between different jurisdictions on the AstraZeneca and its safety. Is there a way that you would have explained that blood clotting risk to the public, or how would you have approached it that may have been different to the way it got rolled out?
So I mean, I don't think the sort of the stock standard explanation that I have is any different to the one that's widely said by many other experts. The AstraZeneca vaccine is incredibly safe. The risks of the clotting syndrome are extremely rare. It depends on the age, but it's about 1 in 100,000 people. 1 in 100,000 people is hard to envisage. I can't even really envisage 100 people. But to put it into context, let's say an MCG can hold 100,000 people. That means that your risk of getting a clot is 1 in 1 full MCG. And even if you do get a clot, the risks of dying are, less than 1 in 50. Those are the kind of numbers that it starts to get quite difficult to understand. And so obviously that's the risks. The benefits are that you can potentially avoid getting infected with COVID, albeit the risks of that were low up until recently. And I think so that's the kind of spiel that usually people give, right? The difficulty becomes is, how do you deliver that with nuance and with patience, and addressing an individual's concerns, expectations, ideas about vaccines at a mass level, at a mass stage, whether that's through the print media, social media, press conferences. That's not something that is, you can just flick a switch and suddenly you have the capacity to do. That takes years to develop, and there's experts that still struggle with that. I went for a meeting with one of the ATAGI members the day before the change in the age group was announced for changing AstraZeneca to over 60s rather than over 50s, and she said to me, "Look, I've done this for 15 years now, and I still just don't really know how to announce this, and I'm so glad that I'm not the one that has to announce it, because it's a tough area." And it's not something that you can communicate easily. yeah, I mean, it's tough, it's complex, and it is fascinating, really, because this is the work, and this is the work that needs to be done, really.
And as an everyday Joe blogs, and from what you've already said, like I think the devil in this situation was the fact that we had so many changes of the policy, and we also had different politicians and chief health officers in different states giving us different bits of information and contradicting each other, which I think for the public can kind of lead to this kind of reaction of, oh my God, it's all too hard and I just want to go get a Pfizer vaccine. Did you kind of sense that, I know you've kind of said that was the problem, but did you sense that was like the major part of the issue?
Look, I mean, again, like this kind of touches on vaccine hesitancy and understanding why people don't get vaccination. And really this is a whole area of research that is just jumping out. And there are a huge number of people that are doing some great work on this. Margie Danchin at the Murdoch Children's Research Institute is one of them. So there's a lot of work going on in Melbourne specifically about this. But really this comes down to understanding human behavior. And it's fascinating and complex, and what influences our motivations and our actions, really. So our motivations are influenced by not only our thoughts and feelings, but by social norms, by social processes. And then the bridge between our motivation towards action is then definitely influenced by things like practicalities, like how easy is it for me to go to the vaccine centre? How easy is it for me to book in? Does it cost anything? What's the service like? Do I get made to feel like I'm a burden, that I'm there, or that sort of thing? So yeah, I think it's easy to blame it on contradictions between politicians, but ultimately it's much more than just, this he said, she said kind of thing, and bringing it down to that. I think one of the areas that medical researchers and that social scientists really that I find quite interesting is this area of heuristics, these shortcuts that we take to make decisions, really, in our brain, because we don't want to expend the mental energy, really. And two of the heuristics, or two of these shortcuts that have become so prevalent and are so glaringly obvious in this pandemic, particularly relating to vaccine hesitancy, is that of the availability heuristic, which is we think about the first thing. We think about the most available information. And what was the most available piece of information, 3 or 4 months ago, was AstraZeneca causes clots, and that's all you need to know. So everyone that was going to get AstraZeneca, they were afraid that they were going to get clots, despite what I've already said, which is 1 in 100,000, even smaller chances of death. And so that kind of heuristic really came to bear in stopping people getting vaccinated. The other is that of omission, where we prefer to not take an action, even though that omission might result in greater harm than having done an action that has lower risks. So, for example, we won't get vaccinated because we're scared of that 1 in 100,000 chance of getting a clot, or 1 in 50,000 chance of getting an anaphylaxis due to the Pfizer vaccine. But we don't think about the risk of getting COVID and, getting a massive clot in our lungs because of COVID. So yeah, to cut a long answer short, I think we really need to find out more about this, and not only just across the general population, but within specific populations, because that's where the work needs to be done, and that's what will get us to 95% of the population fully vaccinated.
Do you think in some ways, I suppose in a perverse way, the fact that we appeared to have handled 2020 quite well, as in lockdowns were successful, there were deaths, but not by any degree to what we were seeing and hearing about overseas. Do you think that almost lessened the impact and therefore didn't make the threat real when as you say, when someone lines up the will I get the vaccination, or will I not bother because I'm not seeing it on my, I'm not seeing the effect of COVID to my friends, family, and peers.
Yeah, I definitely agree. I think in a certain sense, Australia was the victim of its own success to a certain degree. But that's not to say, a huge proportion of our population has family members and friends overseas. We are a traveling nation to a certain degree. So I think our broader sense of the world, I hope, is more than just what we see on the streets around us. But yeah, to a certain extent, I think we were the victims of our own success. But that that's the story with vaccination. Vaccines have made measles disappear. They've made polio disappear, and people think that these diseases are something that can be taken lightly, and yet I've seen measles and I've seen cases of vaccine preventable diseases that end up making people disabled, for years and for decades. So yeah, that's the story of vaccination, really, and of public health, really.
I think that kind of a logical flow-on from what you've said there is obviously a lot of those public health challenges of that scale for things like polio, like we don't realise that's an issue because we all just get vaccinated for it at such a young age. So there's almost an extent to which, or a complacency with something like COVID, which is obviously a global pandemic of an entirely new sort, where we kind of don't really think that that sort of thing can happen here, or there can be a disease that gets us because our health system has been so effective for so long. Is that like a reasonable thing to kind of think after the conversation that you guys have just had?
I would disagree with that because, we do have vaccine preventable diseases, and there is a gross inequity in our society that was present even before the pandemic. You just have to you have to go maybe 3 hours out of Perth, which is where I'm from originally, and you can see kids with scabies or kids with rheumatic heart disease, diseases that have been all but eliminated throughout the rest of the world. So yes, there was to a certain degree an expectation that we would be protected from the pandemic, but really, going forward, I think it's clear to see that just because we're an island nation with a stable health system and stable economy doesn't mean that we can avoid every negative impact. And really, that's very important for people to recognise, and for decision makers to recognise, because when the next pandemic comes, I'm saying that very deliberately, when we need to be prepared, and learning from COVID and learning from the past 18 months will put us in good stead to then pivot to the next one, which will happen,
We talked a little bit before about the UK and where they're at now, and that they've hit a certain figure on vaccination that we are trying to reach in Australia. Assuming that we do hit that 80% rate that's often been termed as the hinge point for us to go back to normal, what does the next 12 months after that time actually look like in your mind? Like what do you actually see? How normal is normal? And what differences in life will there be from pre-COVID?
Just grab my crystal ball out and start forecasting the future. So look, firstly, I think it's very important for me to stress that, it's not over yet. We have a long way to go before we reach 80%. The hospitals and the healthcare workers and people that work much harder than myself will be taken to almost breaking point, if not well past it. But having said that, at 80%, there will be flare-ups of COVID. There will be localized lockdowns. There will be outbreaks in clusters, resulting in morbidity and mortality, death and disease, really. And there's kind of no two ways about that. The national plan puts it very neatly and nicely into these category phases A to D, where we move in between these by certain rates of vaccination. A lot of the assumptions that went into that national planning and that 80% are, for example, good testing, isolating, and quarantine, really. One of the things that we've noticed is that those capacities, those public health capacities, start to break down when we reach high case numbers, which is what's happening currently in Sydney and in Victoria. And to sort of, to put it bluntly, we're at 80%. If there's tens of thousands of cases happening per day, it's going to be very difficult to do anything but lock down regions without having widespread disease or difficulties in healthcare systems. I'm not saying just about the number of ventilators, or, there's not enough ventilators, but I'm talking about the right staff in the right place at the right time with the right equipment, kind of thing. So I think the 80% has a lot of assumptions behind it that may or may not be borne out. So that's the kind of the doom and gloom. The critical factors to our success, I think, will be maintenance of high vaccination rates. So getting the vaccines to the hard to reach populations, really, because the last ones that are vaccinated are always the hardest, and the last people to be reached are always the hardest, no matter in what sphere of public health or in what sphere of clinical medicine. So that's number one, high vaccination rates. Number two, sensible border protections, I think, will be necessary, probably till the end of next year. Sensible border protections being maybe vaccination passports, maybe stratification of risk of countries. So if someone's coming from a high burden country, do we need to put them into an isolation for 2 weeks? A low burden country might be able to do home quarantine if they're vaccinated, for example. And then that ties to purpose-built quarantine facilities. And that's also important for future-proofing our country. We're an island nation that relies heavily on migration. So if we want to keep that going in the future, we need to have a way for people to come safely to the country, even if there's a pandemic. And then I think lastly, it's really, which is the thing that's closest to my heart, and I suspect to many people's hearts, is vaccinating 12 to 18-year-olds or 12 to 16-year-olds, because the national plan so far really just looks at over 16-year-olds. And there's a high transmission potential for people that are young. Yes, COVID might not affect them as bad as older age groups. They still have the capacity to transmit quite a lot. So discounting 12 to 16-year-olds, despite that being a small proportion of the population, their transmission potential is great. So missing them would be a disadvantage not only to the rest of the population, but also to them, because then COVID may be a disease of children, which, giving all of the future of our country a disease that we don't know much about doesn't sound very sort of enticing to me, and I'm sure it doesn't to anyone else in the country.
You've kind of followed quite logically into where I was going to go there, because obviously your next career move is going to be into pediatrics. So, is there the potential for this virus to, and you've kind of alluded to this there, like obviously there's some concerns around what we don't know about COVID, and there's potential that we don't know what the impacts are going to be on those younger generations if they get left behind.
Yeah, so look, I'll be very clear. COVID is overwhelmingly an asymptomatic or very mildly symptomatic infection in children. So it is a mild disease in children. The rates of hospitalization are very low, less than 1% will require hospitalization. The risks of adverse outcomes, like you may have heard about this Kawasaki-like disease or this inflammatory syndrome after COVID, is exceedingly rare. And then long COVID, despite there being some reports recently that it may be up to as high as 7%, if not higher, that is still rare in children. And so the picture at the moment is that COVID is disproportionately affects older people. So that's saying that's, you know, the current state as it is. Moving to the future, which, as I said, I don't have a crystal ball, and it is very hard to predict. If we just vaccinate over 16-year-olds, it will find a way to replicate in children, and it will find a way to transmit across in schools, to parents that are vaccinated, and there's still the capacity for breakthrough infections. So we need to vaccinate over 12-year-olds, because there is now a vaccine licensed for over 12-year-olds, and that's both mRNA vaccines, Pfizer and Moderna. That's number one. Number two, we need to wait to see what the trials say about safety in 6-month to 12-year-olds. And, you know, I would hesitate to guess at saying that the vaccine is safe and effective for those age groups. And then if it is, then we need to continue vaccinating those populations. But really, I think that again is taking just a look at the sort of the children in Australia, but we really should also think about this at a broader regional level, because if there's healthcare workers that haven't received any doses of any vaccine in Papua New Guinea, for example, then it would be, you know, very important for our region and for that country for those people to have those vaccines, because like we saw earlier this year, you know, and to use a short pithy statement, when we're all not safe until everyone's safe. You know, so I think we really need to just broaden our scope and take a much more global look at this.
And I know that you said at the top of the show that it was only a very small part that you played on a team that was involved in developing this vaccine that we've been talking about a fair bit today. But and whether it's yourself or whether it's your peers or the belonging that you may have had from having some level of involvement, how does it feel when, you know, something that you work on, which is very important, but you may have been working on it for, I don't know, not this vaccine, but in general in the area for a decade or so, let's say, and it goes relatively under the radar, and then at this time it has become the most focused on media story really in the world as to what's happening with this vaccine. When is this vaccine going to be ready? Is it safe? That scrutiny, how do you feel when your work is projected on to the biggest stage, or the work of your peers is projected on the biggest stage with all that scrutiny or criticism or praise? How does that feel for you and the people that you work with?
The first thing is to acknowledge the fact that these vaccines were developed by scientists, yes, but at the end of the day, they came to licensure through the work of tens of thousands of volunteers and people that were willing to get vaccinated. So that's the first thing. The scientists are a very small part of the team, and so yeah, there is a lot more sort of pride in this from volunteers, and that was one of the overwhelming things that I heard from volunteers that I've met in the clinic, is that, you know, they were so proud to be part of something bigger and part of the vaccine effort. And that, you know, that they were just doing what they could really, because they felt like they were powerless really sitting at home. So that's the kind of, I think we're part of a big team. The other things, I mean, I feel sort of quite empowered being able to chat to people and being able to say, look, let's have a chat about why it is that you're not interested in this vaccine. What's your specific concerns? And being able to answer questions and have difficult conversations is incredibly empowering. Yeah, and obviously people tend to focus on the negatives, which are the criticisms and the critiques, and this decision was the wrong one at the right time, or the right one at the wrong time, or whatever. But we tend to forget all of the, the 9 good conversations and the 9 people that we actually did have a positive outcome and they ended up going and having a vaccine. So I feel that, yes, there are critiques, but overwhelmingly the experience is positive, and it's important to sort of stabilize ourselves in those positive experiences, and I guess the sort of positive critiques, really.
You kind of mentioned there, and you've mentioned throughout this chat, how much work there is still to be done in science communication. I guess broadly for your field, there's a lot of, news about, new vaccine candidates. For example, the UQ vaccine candidate is back in redevelopment. So I guess my question for you is, obviously we're looking to make, to get research into changing human behavior going, but in terms of actual technologies, are there further developments that we can make in the next 18 months that will be similarly amazing to what we've been able to do in the past 18 months? And again, it's probably a bit of a crystal ball question, but what are we hoping to find by developing more vaccines? Like, what change are we hoping they'll generate for us as this pandemic kind of continues?
I think we'll look back on COVID and think that did such wonders for vaccines and vaccine technologies, that transformed really the progress of vaccines in the 21st century. And I say that because, the Oxford AstraZeneca vaccine, a lot of the technology behind that was developed for malaria vaccines. My PhD supervisor, he spent the better part of his whole life working for a malaria vaccine using the technology that is the backbone for the Oxford AstraZeneca vaccine. And then all of a sudden, within 18 months, they had a vaccine that had been given to 500 billion people from the time which the sequence was published to June this year, I think it was. So these things don't happen in isolation, is the first thing that I would say. And whilst, yes, the UQ vaccine is at the moment a COVID vaccine candidate, their specific technology is all about pandemic preparedness and using essentially it's like a platform where you can just plug in and play the actual the pathogen or the disease that you want. So theoretically, you could use it for the next coronavirus, or for a cancer vaccine, or a hepatitis B vaccine, those sorts of things. So yes, the COVID UQ vaccine is important, and that's important because it will translate to other diseases, and the insights that we generate from that may be able to help us move forwards in terms of other diseases. I think the lessons that we learn in terms of science communication from this pandemic will also hopefully help us move forwards in terms of how to put in the groundwork before a pandemic, and having grassroots links to then quickly deploy and quickly be able to roll out vaccines throughout communities. So I'm hopeful that this will help us for the next disease that comes along, but then also to cure those diseases that have been neglected for decades.
So you see that this is a continuum. It's not a discrete project that we're working on. We're working on COVID-19 now, where we are going to take the lessons of it to use in a lot of different ways over the next 20, 30, 40, 100 years.
Definitely. The work that led to the Pfizer vaccine started in the 1990s. It was literally just someone saying, I'm going to inject some RNA into a mouse and see if I can generate a protein. I mean, it was obviously much more eloquent than that, but I'm just not capable of describing it. So yeah, that stuff doesn't just happen overnight, and good science doesn't happen overnight, much like good qualitative research doesn't happen overnight. It requires decades of brilliant minds consistently chipping away at it, getting it wrong, and then eventually getting the right step in the right place at the right time. One
final question from me, which might seem very, very obvious, Andrés, but if someone you knew was vaccine hesitant, what would you say to them? What's the first thing you'd say to them?
I mean, so I would take a step back. I wouldn't say, I would try and ask them about why it is that they're, what their concerns are, what their ideas about vaccination are, and what their expectations are, really. I think in this day and age, it's very easy to paint someone as anti-vax or as vaccine hesitant, but really that we lose the nuance in our individuality then, and we stop seeing people for who they are. So if it's someone that's had endometriosis and they're scared that they might be infertile, then exploring those fears and really engaging with them earnestly and honestly, and trying to understand their reasons for just delaying their vaccination a bit, and reassuring them that, for example, in this case, that the Pfizer vaccine has been given to millions of people that are pregnant, and there's been no increased rate of stillbirths or preterm birth or whatever it may be. So I hate to say it, but it is a much more of an individual discussion that requires care and attention and some humanity, I think.
I think that's a really strong message to finish on. I know this conversation has made me want to go back to year 11 and reopen my biology textbook. I'm sure you feel the same, Shannon. Thanks so much for joining us, Andre. It's been an absolute pleasure, and I'm very grateful for your time, and I know our firm is as well.
My pleasure. If I can just finish with maybe just a few quick messages. If you haven't been vaccinated, please at least have the conversation about getting vaccinated. If you know someone that hasn't been vaccinated, please talk to them and have a chat about to them about why that is. And if you have the capacity and you're willing, then donate to the COVAX initiative so that you can vaccinate, or you can help vaccinate a healthcare worker or someone else throughout the world. Thanks very much.
No worries. And Shannon and I will be back next week with the second episode of our series on COVID recovery with Paul Guerra, who is the CEO of the Victorian Chamber of Commerce and Industry. We'll see you then.